Hello and welcome to another edition of Health in the Heartland, a program dedicated to the health issues that affect you. I'm Karen Blakelock. In this episode, we will address cancer awareness, prevention, and advancements in treatments. My guest this episode is Dr. Adam Lai, oncologist with the Cancer Care Center at Hardin Memorial Health. Welcome, Dr. Lai. Let's start a little bit with maybe how cancer, the statistics in Kentucky relate nationally to the incident rates that are out there.
Sure. So currently, Kentucky has the unfortunate distinction of being the most cancer-prone state. So when you look at the statistics and the databases that are compiled, we're unfortunately #1 overall. I believe Mississippi is #2. And in women, we're #1 overall, and in men, we're #2 overall. So when you compile all the numbers, we have the highest rate of cancer in our state compared to any other state in the nation.
Which is a concern, and that's kind of the awareness and the eye-opener. What can we do and what's going on with cancer in Kentucky? Let's bring that on down a little bit to Hardin County.
Sure.
Hardin County, where do we rank?
So Hardin County, when you look at the national average, we're unfortunately above average. We are right now seeing about, from 2006 to 2010, which is the last time they really compiled the numbers, we had about almost 3,000 cases of cancer over that time. So we're seeing a fair number of new cancer diagnoses in the Hardin County area, and it's certainly above the national average.
Right, and I think you brought up some good points there. You said, new diagnosis. So I'm sure our viewers at home are saying, what can we do as far as prevention? And then maybe are those rates up because of the advancements as far as diagnosing and how we're able to maybe find it at an earlier stage. So let's talk with maybe prevention first. What can we do to prevent cancer?
Sure. So, the most serious risk factors for cancer, there's really only two that you can't modify. One of those is getting older. We're all going to get older, whether we want to or not. And as we get older, our body loses the ability to fight off cancer some. And then the other thing is also any genetic risk that you've inherited from your parents. And then, unfortunately, there's sometimes not much we can do about that risk either. But the other things that we can do something about, like smoking, diet, obesity, physical activity, limiting our exposure to sun or UV rays, and a few other things. There are actually quite a few things that we can.
Those are mostly lifestyle risk factors.
Exactly,
so we can kind of control some of the choices that we're making as far as making sure we're getting some physical activity, making sure we're looking at our diet, maybe choosing to smoke or not to smoke. And
right.
Of course, that's a key one right there. And then some things you can't control necessarily as much, but environmental. Correct,
That's
too.
right.
Your exposure maybe to chemicals or ionizing, different things that might be out there too.
Some patients that have had exposure to ionizing radiation, whether it be through treatment for cancers or other disorders throughout their life,
right.
That leaves them at risk of second cancers down the road. And then also with exposure to chemicals, either at work or other hobbies that they have. Some people have significant chemical exposure throughout their life as well.
Sure, so a person really needs to look at themselves and look at their genetic background, obviously. Mom, dad, what they might be at risk there. Their lifestyle choices that they've made too. It kind of all compiles together, correct?
Right. That's right.
And then also maybe environmentally what they've been exposed to too. So let's talk about maybe diagnosing then and how we have made some advancements over the years in actually finding out maybe at an earlier stage if we can cancer risks.
Sure. So now the worst time in history to get cancer really was 1991. That was the peak of cancer mortality. And since that time, so roughly 20 years, there's about a 20% risk reduction that you would die from cancer now. So we've made really good strides in cancer treatment. But part of that is also we've gotten better at diagnosing cancer early. So whether it be with screening mammograms or colonoscopy, Now the newest thing is CT screening for certain smokers over the age of 55. All these things are helping diagnose cancer earlier. And then the other thing that we've gotten better at is not just diagnosing you with lung cancer or breast cancer per se, but actually finding out exactly what type of lung cancer or breast cancer you have, because we know now they're very different.
Exactly, and I think, you know, as I'm listening to you, I would know that I need to, again, look at those risk factors and then also make sure I'm getting the preventative things that I can do as far as the screenings and the testings. We really encourage people to take advantage of that, correct?
Yeah.
And make sure they're getting their mammograms at the age based upon their risk factors and talking to their physician. The colonoscopy, obviously, and then you mentioned the new one with the lung cancer CT scans too.
Right.
So really making sure that it can be found and then hopefully be treated, correct?
Right, that's right. I see patients every week in clinic that have a family history or risk factors, and they haven't done some of these things, and I just have to kind of give them a gentle push and say, you really need to do this.
Right.
And a lot of times that will help diagnose early cancers that are curable, and if they would wait, then a lot of times these cancers aren't as curable if we catch them later.
Absolutely. Now, talking about, you said the mortality rate, I know we've had advancements as far as treatment is concerned, and if I'm using some of the terms right, it used to be called kind of an atomic bomb approach, and now we have moved to, you said a smart bomb, is that correct?
That's my,
okay.
That's how I explain it. So in the past, in the history of cancer treatment, we didn't know as much about cancer. So the approach was that we would deliver a type of treatment called chemotherapy, and chemotherapy attacks rapidly dividing cells. And that's why people lose their hair oftentimes during chemo treatment. It's also why you can have problems with mouth sores and that type of thing. Those areas of the body are more rapidly dividing and rapidly growing and repairing themselves, just like a cancer cell is. So in the past, when we've treated cancer, we have kind of had to take out some healthy cells, and at the same time we're taking out the cancer cells. So that's been the classic approach, or what I call the atomic bomb approach, because when I deliver that type of chemotherapy, it can't differentiate a non-cancerous fast dividing cell versus a cancer cell. So it takes them both out, and that's how we've treated traditionally. Now, since we know a lot more about cancer and the types of cancer, we can actually identify specific mutations, specific defects or proteins in cancer cells, and we have a whole host of drugs that will preferentially target that cancer cell that's expressing that protein or that defect, and hopefully not attack any of the non-cancerous cells that don't have that defect. And that's more of a targeted, or what I call a smart bomb approach, kind of similar to, you know, in the past when you see the military videos of one house that's been destroyed and all the other houses are left standing. It's a similar thing. The drugs are going in and preferentially targeting a cancer cell with a specific mutation, which is really quite amazing.
That is, and so we've had advancements as far as really, as you said, kind of honing in and targeting, and that's advancements also pharmaceutically, correct?
Correct, yeah.
And through research and different things too.
That's right. Most, but not all these drugs are also delivered with a pill. So patients are no longer all the time having to come in and have an IV infusion. Some of them still are through IV, but many of them now are a pill form. Yep.
So actually their quality of life, in a sense, they're home. They're not having to come and have the treatment per se. Some, of course, this is very individualized, but are able to maybe have the treatment through the pill form and be at home with their family and different things too, correct?
That's right, yep.
What about side effects? Are those changing a little bit too, or again, very individualized?
Yeah. So every week in my clinic, I also see patients who are somewhat reluctant to get treatment for their cancer, and sometimes that comes from them either having a family member or a close friend that got treated 15 or 20 years ago for their cancer, and they had horrible side effects. And the one that always gets people is the nausea. Nowadays, we have a lot of medications, actually 3 or 4 whole classes of medications. Each class has multiple options, but a lot of these block the nausea receptors in the brain, and they do a really good job at blocking nausea. Can't block all nausea, but we do a really good job of getting people through treatment as far as side effects go.
And I heard you say we, and that totally is what the Cancer Care Center is about, a team approach, correct?
That's
it takes a team to take care of that patient. Who actually is on that team? I know the physician, we have dietitians.
We have, so we have multiple physicians, multiple oncologists. We have radiation medicine. Many of the cancers nowadays are treated with either chemotherapy or radiation, or oftentimes both at the same time. So that's a team approach. The radiation department and I work together. And then there's also dietitians, nurses, techs, radiologists, surgeons, vascular surgeons. I mean, we have a whole team of dozens or probably hundreds of people. And every patient now is a tailored approach to what would be best for them.
Right, and those that are working in that area are very specialized, actually have gone on for certifications in oncology and cancer care, so they're really treating that patient and knowing how to take care of them.
That's right.
I think, and you had talked about too, that this is very individualized. If one person has lung cancer and another person has lung cancer, it's not necessarily going to be treated the same way, correct? Same thing with breast cancer, et cetera.
That's right, and nowadays it's even more specialized than that. There's, to use lung cancer for example, there's lung cancer, and then there's non-small cell versus small cell lung cancer. And I tell people that's just how it looks under the microscope, and they behave differently. And then even with non-small cell lung cancer, there's adenocarcinoma, there's squamous, there's large cell, there's all different types of non-small cell lung cancer. But even now in an adenocarcinoma, you have different types of adenocarcinoma that are treated completely differently. So there are dozens of different lung cancers now, and they're all treated differently depending on what mutations I find or how they're behaving, how quickly they're growing, what stage they are. All these things play into the type of care plan that I develop for patients.
Which is very specific.
It is.
For that patient.